Welcome, everyone. We're going to get started here, and if folks trickle in, we'll just welcome them to the party. These are our opportunity to sort of dive a little deeper into the topics, and we will definitely have an opportunity for questions. We're going to hold those until about the last 15 minutes of our session. This session is talking about innovative solutions to increase mental wellness and add value for our employees and increase productivity and employee retention. So as many of you, I'm sure, are aware, employers are a large purchaser of healthcare services, an economic driver, and we're going to talk about how the collective power of those decisions can shape the mental health landscape in this country. We've got some great panelists today, and so I'm pleased to introduce you to them. I'm going to start with, let's see, I'm going to work this way. So Dr. Mark Jones is the General Director of Health and Medical Services at the Union Pacific Railroad. Mike Thompson is the President and CEO of the National Alliance of Health Purchaser Coalitions. Gary Cohen is the President and CEO of Employee Resource Systems. Nicole Thurman is the Vice President of Talent Management at CHG Healthcare, and Chris Wolfington is the CEO of FinPay. So we heard from our panelists this morning a number of key elements related to the employee decisions around, or employers' decisions around employees. We're seeing an expansion in what EAPs do. We're seeing employers work with their wellness companies, as we heard this morning, to expand what they do around mental health services, not just because of the connection with physical health, but also as an outcome in and of itself. And a lot of this is around moving from, as we heard this morning, EAPs as a checkbox that employers have to offer, to really viewing them as an essential part of what happens for their employees. We also heard some references to using data and making more informed decisions this morning, and so we're going to talk about all of those things today. Mark, the Union Pacific Railroad was a pioneer when it came to creating access to treatment through the benefits, and you did a lot of work as part of that process to understand the needs of your employees. Can you talk a little bit about how you went through that needs assessment and how you used that data to develop the program?
So just a little bit of background before I answer that is we have about 40,000 employees in 23 states. And 95% of our employees are union employees, 13 different unions. And our plans encompass the unions all together, so we don't have separate plans for separate unions. It's a comprehensive plan. And one of the things that's unique about our industry, as probably many industries you're familiar with, is it's a 24/7 operation. And over half of our employees don't have a set work schedule, and that if they're in train service, they go when the freight is ready. So they have many challenges in terms of their own emotional and physical health that we need to take into account. Poor sleep cycles, extended time away from family, demanding work schedules. Our engineering staff, for example, the folks who are fixing the roads and the track and all those kind of things, they work 8 days off, 7 days on, and so they might live in Salem, Illinois, but be working in Albuquerque, New Mexico this week. And so given those kind of things, you have to have a really flexible system to be able to meet their needs. And so you have to have providers that you have relationships and connections with across the nation so you can get people into services kind of where they're at and when they need them. One thing I think we've done really well, and just a closing comment and then we'll pass it on to the next group, is I think the average length of time to get somebody into care for behavioral health assessment and treatment on an outpatient basis, I think the average is about 22 days from the point of somebody makes the referral times they get to see somebody. Our average is 5 days. And the reason is we have a very robust network, and we've developed relationships with preferred providers around the country. And we essentially train them about the railroad culture and what our employees need. So that goes back to the needs assessment, because we think that pairing between what those folks are up to, like any other profession, whether it be the medical profession or whatever, but the transportation world, since it's so fluid, is really unique. So we have about 35 or 40 key providers around the country who were able to give us immediate access and immediate needs. And we do find that that our rates of depression and our rates of anxiety and our rates of sleep disorders are probably about twice the national average. And that I think the average rate of depression in the country is 9 to 10%. We find in our wellness studies, HRAs, other data that we take, it's about 16 to 17%. So in that sense, we have to be really flexible and make sure that we're meeting the needs of kind of a round-the-clock workforce.
Yeah, I think we're going to hear a lot more about this importance of data. Mike, as you work with purchaser groups across the country and looking at how to develop a plan, what are the questions that folks should be asking their third-party administrators about, their utilization and what kind of data becomes important to them in that process?
First of all, just a little bit of background. The National Alliance of Healthcare Purchaser Coalitions is the umbrella organization for employer coalitions across the country. Every employer in the country, healthcare is actually their second biggest spend. After labor, healthcare is the second biggest spend. Here in Chicago is the Midwest Business Group on Health, and they're here today as well. When we look at some of the key health issues that companies face, mental health is right up there. In fact, a couple years ago, when I took this role 3 years ago, we did a survey of the coalitions on where mental health was in terms of the amount of activity in the coalitions, and it was second at the bottom. And today, we did a survey of coalitions, and 100% of the 30 coalitions that did the survey are working on mental health or planning to do so in the next year. So this has come full circle as being one of the most important issues, not because it's a new issue, it's because I think we're becoming aware of how broke the system and how critical it is to our people. And so you asked about data in terms of what should employers be expecting, and we heard a lot of discussion on the main stage about what we need to do to break the stigma, improve the culture, and we're totally on board with that, and our coalitions are helping to educate and lead some of those efforts. But what I usually say when I'm in this is that train is going downhill. I want to use the train.
Everybody does.
That train is going downhill. You are piling on. The momentum is totally in our favor around that. But the system is not. The system is getting worse. And you heard the issue of waiting 20 days to get an appointment. You got lots of names in your networks, but a lot of people are starting to describe those networks as phantom networks. Try to get an appointment with one of those names if you're a new patient. And so the issue is, and then if you look at your data and you look at your usage in network versus out of network for your mental health versus everything else, again, it may vary by company, but what most of us find is it's way higher out of network. Well, if you know what mental health services cost going out of network, you can imagine the barrier to care that is. If the only way you can get access to health services in a reasonable way is out of network, you got a problem. And my belief is that's not going to fix itself unless we collectively focus on it. And so the coalitions, the National Alliance, is making this system reform a priority, not just limited to the networks, though, because we also need to be looking at primary care and other providers to integrate behavioral health into the system, and beyond that, to do so on a more accountable basis, on a measurement-based basis. Yeah, there's a lot of solutions to extend care, things like telehealth, telebehavioral health, and we encourage those. But fundamentally, we need to provide better access. And so we have actually developed and worked with folks like the Kennedy Forum and Henry Harbin to develop data requests that employers can submit to their carriers to hold them accountable and assess what they're doing in some of these areas. Again, collaborative care codes, which is the integrated behavioral health solution for primary care. The great news is that the great majority of health plans have turned those codes on, meaning they will pay and reimburse for that. The bad news is claims aren't being submitted, which means that while we have most of the drugs for mental health being prescribed in primary care, we don't have mental health professionals in that mix in the treatment of mental health at primary care. So there's lots to talk about. I'll stop there.
Gary, you have both co-founded and own an EAP and are a therapist yourself. What do you see as some of the biggest challenges that employers have when promoting an EAP, and what are some of the solutions that they can utilize? Because the EAPs are such an important part of what we've just been talking about.
Well, having been in the, good morning everyone, having been in the EAP field since the mid-'80s, I've seen a lot of different changes that have occurred. From a promotional standpoint, think about how many emails you get per day into your email box. How many of them do you not read? How many do you delete? So employers believing that they can just start just massively sending emails to employees about the EAP is not going to increase utilization. I'm firmly of the belief that you have to get in front of people, you have to do presentations, you have to give them a physical card with information on it that people will remember because somebody came and spoke to them. We see utilization jumping up when we do that. I've spoken with several of the healthcare consultants, and everybody wants apps now. Everybody thinks apps are the end-all be-all. Nobody uses them. We also, as employers, I encourage you to go back to your work site and encourage your organization to not go with the embedded programs. The embedded programs have a place, okay? An employer can do lip service and say, we have an EAP because we get the free program. Those organizations get paid pennies for providing that service. There is no incentive to increase utilization. When you go with a fully funded program where you're spending the money, you're going to get a better return on your investment in helping your employees. You also have to do a great deal of promotion with your management team and get rid of that stigma as well. When you present to management and they see that the program is useful and helps them manage employees with performance problems, you win there. When the managers themselves use the program for themselves and their immediate family members, there's another win. The other piece you need to recognize is that EAPs are not just about mental health or substance abuse. The EAP is really the psychosocial service agency comes to corporate America. We deal with drugs, alcohol, legal, financial, marital, daycare, elder care, any conceivable psychosocial issue that any one of us in this room could be dealing with are the things that we get asked as EAPs to deal with. If the company can't figure out what to do with something, dump it on the EAP. We become experts at things that we weren't trained to do necessarily, or we have to find the resources for it. Bottom line is, you've got to get in front of people, you've got to promote the program, you've got to foster it, you've really got to get behind it. If you don't do that, there's not going to be high utilization. In some of our organizations, they send out a postcard that goes in along with the EOBs, and it falls out of the EOB and the family member picks it up. One of our labor union groups has a 50% utilization by family members because that information gets to the household. And the other thing I'd like to touch on is, we've been asked to, we've been told, well, young people want to text. Imagine texting your innermost feelings and depression to some stranger. It's difficult enough to pick up the phone and call and say to somebody on the other end of that line, I have a problem and I need help. If you text your problem, you're really divorcing yourself from the true emotional things that are going on, and you're not going to necessarily get all the help that you need. It may be a first step, but it's really important to foster the use of the telephone the old-fashioned way and encouraging people to be seen in person for EAP sessions. One last piece, and then I will turn it over to my colleague to my left, is that one of the speakers earlier today mentioned something about increasing the premiums that are paid for EAP for people to use services. EAPs go at risk like an insurance plan. So when you say utilization is low, it's no different. You're not going to get everybody using the health insurance plan every year. just because they have it. It's the same thing with an EAP. We go at risk and charge a certain number of dollars to provide service and assume that a certain percentage of the population will use it. Our fear as EAPs is that because the pricing structure has been bottomed out by competition, by being marginalized, and by being commoditized, we have to reduce our rates. And so we can't provide the high levels of service that we used to. There was a time when you could charge $1.70 to $1.90 for an employee for EAP services per month. Now you're lucky if you get $1. And then you're asked to do all these other add-ons and still provide 24/7, 365 coverage and help people. The other piece is that when there's a crisis in an organization, there's a shooting, another 9/11, what happened in New York yesterday with the helicopter. First persons that get called are the EAP. We are like the first responders. And we have to be compensated for what we do in order to provide the service that we do. And that also encourages people to go into the field. If you keep marginalizing what we do and salaries keep going down, people are not going to enter the field. So those are some things I hope you'll think about as you're looking at your programs.
My name's Nicole Thurman, and I work for CHG Healthcare. And I wanted to start by saying, no, I did not color coordinate based on the Kennedy Forum branding, although that was a... Oh, I know, right? Purely chance. But I wanted to start today... actually, you have a question for me first, right?
Mostly I was going to ask you to talk about your experience, Nicole, because I think the things we've heard about the importance of EAPs, the role that primary care plays, the role of benefit design, are all things that, you've, when we talked offline, have talked about being really important to how you guys approach this at CHG Healthcare. And you have multiple locations for your employees, which adds another layer of complexity, as we've heard as well. So I just kind of want to invite you to talk about that experience for folks and how you brought it all together.
Terrific, thank you. First, thank you for allowing me the opportunity to come and speak about something that I'm very, very passionate about, and that is providing quality health care, convenient health care, and no-cost or low-cost health care to our employees. We actually started our journey with wellness and through on-site clinics. We have, just to give you a little bit of background, we're a healthcare staffing firm. We staff doctors, nurses, and allied healthcare professionals all over the world, mostly in temporary assignment. We have 7 offices. Our largest is in Salt Lake City, 1,400 people, all the way down to an office in Edmond, Oklahoma that has 40 people. So we have varying sizes of offices that we're trying to tailor our benefit programs to. In 2012, we added an on-site clinic in our Salt Lake City office, and through that process, we realized quickly that our providers were trying to treat a lot of underlying behavioral health issues, depression, anxiety, etc., and we're really ill-equipped to do so. And so we're hearing from them, we really need a mental health, behavioral health person here, a counselor on site. Also screaming at me was our pharmaceutical utilization. We had our top 5 drugs were anxiety and antidepressants. We also had managers and leaders coming to me saying, I'm spending an exorbitant amount of time coaching people in my office, hours at a time, hours per day, helping them navigate through their personal issues and things that they're going through. So all of these different indicators, basically were staring me down, telling me that we had to come up with a solution to better support our people. And we are a very people-centric company. We do believe in taking care of our people, which helps in this battle. But we decided at that point that we would work with our on-site clinic vendor to add mental health counselors. And we did that about 2 years ago. This slide likes me. Some of them will be. We started adding mental counselors onto our on-site clinics, and we were greeted by a phenomenal ramp-up period. Within 2 weeks, she had a full set scheduled visits. And they did that through two ways. We actually didn't even promote it across our organization. We just were supporting the providers that we had at our on-site clinics. So they were providing a gateway into that resource. We also support our EAP programs. So all of our providers in our on-site clinic, all of our providers who visit our offices who don't have an on-site clinic, which includes mental health, know about our EAP resource. They provide that resource to the office. They talk about it. They talk about the value and what to do if they're not available. And we also work diligently with our insurance companies to carve out networks and find out-of-network providers providing mental health counseling services so that we can bring them into our network. So we're trying to do everything and anything innovative that we can do in order to better support our employee population, because these are the underlying disease states that will turn into heart disease, that will turn into diabetes, that will turn into all of these things that will end up costing us a lot of money long term. And we just believe it's the right thing to do.
Thanks. So Chris, one of the things that has come up in the conversations is around sort of folks going out of network, but we also know that a lot of employers are moving to high deductible plans, and so I think the combination of those things creates a financial strain. I think that the data is that the majority of households in this country cannot cover an unanticipated $400 expense. I know, I like the data. So talk about sort of what you all are doing to try and help employers navigate the financial challenges that go along with treating mental health.
So first, let me just show of hands real quick. Who themselves, family member, friend, has a story about a medical bill that didn't expect, was big, huge, no one explained, complicated, don't know what it means, right? Okay. That's the problem, right? So here's some crazy statistics. This is healthcare in general, not just behavioral health. Last year, there was over $400 billion with a B, co-pays, co-insurance, deductibles, out-of-pocket costs for the U.S. consumers. Only 19% of that money was ever paid. That leaves a $320 billion gap in the healthcare ecosystem. So when you hear all the politicians on TV talking about healthcare, Medicare for all this stuff, what they really don't want to say is point to everyone in the audience is healthcare is crazy because you guys don't pay your bill. No politician ever gets elected by pointing out the consumer, right? So as a result of these, and most of it is due to lack of education and a lack of proper timing on when we talk to consumers about what they owe and being more transparent. I mean, I know I want to pay my bill, but I don't plan to get sick next Tuesday, number one, right? No one plans to get sick. And if $400 is the magic number, and that is a well-studied metric, but the average out-of-pocket expense for someone for an acute care encounter is like $1,200. That's 3 times the $400 number. Behavioral health, I have a behavioral health customer. Their average out-of-pocket costs for addiction treatment is $3,800. And every other facility a patient go to says, yo, $3,800, how are you going to pay that today? And here's the math nationally. 1 in 3 American families say that they delay or cancel care that they need because they can't afford the out-of-pockets. Behavioral health is significantly higher than that, but there's not enough segmented data to pinpoint it. But on a national level, that's it. Leading cause of bankruptcy, personal bankruptcy in the United States, medical debt, right? Healthcare is now the 4th largest household expense. The cost shift in cost going to the consumer, I don't think there's anything wrong with that. I think there is a responsibility. But when you have a graph of cost shift that goes like this, showing what patients owe, but the education and the payment options to meet those obligations is flatlined, smart employers are saying this financial stress is just as detrimental to my business and the productivity of my workplace than my physical wellness, my mental health wellness, because don't kid yourself. I've been there. I'm father of 4 kids. I've had my moments where I literally didn't know where the next dime was coming from. I'm paying $3,000 worth of bills with $2,500, and if you don't think that's affecting your employees, you're crazy. And so what we did, we partnered with a company called WellWorks, and we've grown out a national program. is we created a financial wellness benefit in the workplace around healthcare. In other words, imagine, I'll call him back. Imagine before you get your care, somebody calls you up on the phone and says, hi, your employer cares about your financial health as much as your physical health. So they give you free access to a payment specialist like me to help you navigate what your financial responsibility is going to be for your upcoming surgery, admission for this care, whatever it is. We want to make sure we answer all your questions. We want to make sure you understand what you owe, why you owe it, and how the health plan is determining what your costs are. We want to make sure that you have cost-saving strategies. Are you going to the right providers if the care is equal, going in-network versus out-of-network? I want to explain what the billing and claims process is. What is an EOB and why do you get it? And what is a bill from the provider and why are they different? If I use a health savings account, flexible spending account, and HRA, how does that help me and how can I help you save money? And then once we figure out and you say, okay, I get it. I now understand before I get my care what I'm going to owe, that same person is going to say, now let's talk about how we help you afford it. Some employers are even going to the distance and helping off. So they say to the employee, yes, I just gave you a $5,000 high deductible health plan, but I'm going to give you the financing mechanism to make that $5,000 more digestible, more affordable. There's nothing wrong with us as U.S. consumers having a stake and a role in the cost of getting the care. It's just the reality. But the employers, providers, and insurance companies have a responsibility to give that consumer the proactive pre-care tools and education so we as consumers can make healthy, reasonable, and rational financial decisions regarding the cost of our care. And the smart employer is jumping ahead of that because they're recognizing that financial wellness is just as important as physical wellness, especially when that translates to mental health.
So picking up on a theme I think we heard from the panel this morning, and that has come up a little bit here, is that employers have started to think about prevention on the physical health side, right? So we're seeing investment in things like programs to prevent folks from migrating from a pre-diabetic state to a diabetic state, both for a cost savings ROI, but also for sort of the same retention and productivity things. So a couple of you have kind of talked about this, challenges of stress, sleep, some of the things that sort of contribute to the development of, or sort of, process along the way. How, either as an employer or as, groups working with employers, are you seeing folks kind of trying to address not just the treatment side, right, that sort of expensive, severe tail end of the distribution, but also the other side of the distribution of mental health need on the prevention and sort of keeping folks from migrating down that risk curve? So, maybe dive in here.
I'll throw in what we're seeing. There's a broad movement. You hear the word well-being being thrown out a lot. And what's interesting is when you see the broader movement towards well-being, getting beyond physical, looking at social, looking at purpose, looking at financial, all of those factors, it turns out, are root cause issues for mental health. And so while sometimes people see emotional health as being part of that pie, and it is part of that pie, it turns out it's very interrelated with all the other parts of that pie. That the stress elements often at their root cause is financial, often at their root cause is loneliness and isolation, and those issues, if you deal with them, can mitigate the downstream issues.
The other thing I'd like to add is that we get called by employers who say, can you come and do a stress management workshop for our employees? But can you do it in 15 minutes? Okay? You're all laughing, but that's the reality. How fast can you do it? Because I've got to get them back on the conveyor belt or get them back to their offices, or how about a smoking cessation program? But we want to do it at night because we don't want to take people away from their jobs. We want to reduce our costs for our insurance costs because of claims for cardiac and cancers, et cetera. But we don't want to have people out of work to get these things. So there has to be some push to either you put it out there to begin with, and you say, I'm going to spend the money, I'm going to be a good employer, I'm going to give these things to my people. And if I'm not, then don't do it. Don't lie.
I think for our organization, we try to tackle that from a lot of different perspectives. It's not just about our insurance program or what someone can get at the on-site clinic, although that's a component of it. It's also about providing flex time. It's about providing servant leadership. So our leaders are held to a very high bar so that they're not jerks in the workforce, and that they provide a good environment for their team members. It's also about transparency and being honest. It's about really treating people the way they want to be treated. And I think that we as employers have a responsibility to do so. And I think those employers who don't get on board and don't do so now are going to have a hard time attracting and retaining talent long term.
That's a great point. So I'm going to take the
Can I
opportunity.
just add one thing really interesting to that? I'll be quick just to add math to that. So I mentioned there were $400 billion of out-of-pocket expenses, only 19% paid. Patients that are engaged pre-care pay 85% of what they owe. But here's the most important statistic. Because you got in front of it, what you were just saying, and being more proactive, the patient satisfaction rate on patients that pay is 98.6. The patients that are in the 19% category, it's less than 5%. So getting in front, being more transparent, being more proactive, the math proves that it works for everybody.
So I want to give the audience an opportunity to ask questions as well. We have volunteers with microphones, and so because we are recording, we'll ask that you ask your questions into the microphones, and we'll have a little bit of time for that. So I think we have one down here.
So hi, I'm Brad Lerner here at the Beacon. I'm curious about your experience with telehealth and behavioral health from the employee perspective. You've been finding employees wanting to take that up, or it seems like mental health would be a good fit for that, but I'm curious what your experience has been and your impressions of it.
So I'm going to repeat the question just for the recording. The question was about the interest and utilization of telehealth, and particularly telebehavioral health by employees, and are folks interested in it, and are they using it in your experience? So,
Well, I'm not an employer in that sense, so I'm going to talk about what I hear, and then I hope that employers will weigh in to kind of see what they hear or what they've seen. First of all, it's one of the hottest growing benefits with employers is introducing telebehavioral health, and frankly, it's a rational reaction to the fact that we need better access to behavioral health, and in theory, it is readily available. In some parts of the country, some states, there's a dearth of psychiatrists, period, forgetting about whether they're in the network, and telebehavioral health plays a very critical and fundamental role in that. So there's a lot of positive, and I think the evidence that I have been told, I'm not an expert, but the evidence that I have been told is that treatment through a virtual setting is just as effective as treatment in person. So that's the good news. The bad news is, I think what somebody referred to today, is that the uptake isn't what it could be or should be still. And interestingly, it's not, this is a good example where there aren't usually as significant financial barriers to using telebehavioral health as there is to using in-person care. And yet we still don't see the amount of use that we could. And so my view, I think our view collectively, is telebehavioral health is a key part of a system, but it's necessary maybe, it's helpful certainly, but it's not going to be sufficient. We still need access to affordable in-network care.
I think the other thing, I'll chime in here too, is picking up on a point Gary made earlier. It's important to distinguish telehealth services where you are talking to a live person from the proliferation of mental health apps out there. There's some great data out of the Beth Israel Deaconess Medical Center, which is a Harvard hospital, that really says buyer beware around some of these apps, that the person or bot on the other end, it may not be providing quality care, and it could be a situation where someone choosing that over a qualified provider, you end up doing more harm than good. So I think there are some unresolved questions around the role of those technologies in serving that gap. And I don't know, Gary, I'm sure you want to chime in here too.
There's a great need for telehealth, no doubt about it. One of the problems that we have in the mental health arena, and I can't speak to the physical health arena, is that as mental health providers, we are licensed within the state where we practice. So I am a state-licensed, Illinois licensed clinical social worker. If I am providing services over a televised process to somebody, even in Wisconsin, am I violating Illinois law or Wisconsin law? And this is something that has to be ironed out, okay? Because I'm not licensed in those other states. As an EAP, there's a fine line between whether we do therapy, counseling, or assessment and referral, which goes back to our core values. And we could sit and talk about the semantics of all of that all day long. Bottom line is that we don't provide therapy, and an EAP does not provide therapy. One other point I'd like to make is that we have problems finding quality providers who are willing to take insurance, who are willing to deal with the getting reimbursed. And a lot of people are just saying, you know what, I'm just going to take private pay patients. Trying to find a psychiatrist to see somebody who needs medication management is almost an impossibility, or the waiting times can be 6 weeks, 3 months, 4 months. Now, I live here in Chicago in an urban environment where we have lots and lots of providers. It takes months to get somebody in, and that's a problem. And until we start to value what those mental health practitioners do, psychiatrists, psychologists, social workers, licensed mental health practitioners, until we place value on what those people do, things are not going to change.
I think we have another question down front. If you want to ask it, I'll repeat it for the audience so we don't have volunteers running back and forth. So the question was around use cases where folks are demonstrating that this holistic view of funding mental health care is making the business case, and if there are any examples of that. So I'm going to...
Yeah, so I'll address that. One thing that's unique about the railroad plan, and I'm not on the benefits side, so don't want to present myself as an expert in that, but familiar with it, very familiar with it, in that the railroads negotiate for their benefits collectively. So all 6 major railroads have what we call a national plan. I think it's actually the largest plan in the nation for United Healthcare. There are some pockets of Blue Cross and Aetna as well, depending on how the network goes. So there's a great deal of, it's self-funded, and it's a joint plan between management and labor. And so we have been very fortunate over the years to not be restricted by the kind of typical things that I'm hearing that are barriers and that are difficult for everyone here. And that, for example, if you go to a behavioral health provider or you go to your physician for whatever, you have a $20 copay and that's it. And there is not a yearly deductible that you have to meet for this plan. So in that sense, we're economically invested in our employees, because the other thing is, and this will probably drop some folks' jaws, is there's no limit on the number of times I can go. So if I identify a therapist in Houston that I'm working with in the network as an employee, I can go to them 60 times a year and just pay $20 a session. And so that's really unique in the world, and that there is no limits on that. The other thing is, for example, here's another example of us being invested in our employees is if we send somebody to substance abuse treatment, that is covered at 100%. And so those kind of figures that you talk about, and so we don't. So it's really unheard of, and so some of the barriers that exist in other parts of corporate America and other businesses, we don't have. And I think in some sense that represents an economic investment. And we did some studies with our finance group and a carve out of our insurance, one of our insurance vendors. I won't go into all those details, in which we were able to show kind of the typical return of pre-EAP treatment versus post-EAP treatment. Their medical spend for that employee, overall medical spend, went down about $200 per month per employee.
So, Joe, I think the other thing, the data that might be helpful here is there's a study by Dr. Brad Evanoff at WashU in St. Louis that compared productivity measures and found very little agreement between about a dozen different measures. So as we look beyond medical spending to talk about that ROI, I think we have a gap in our ability to study the impact because we don't have great measures of productivity, and a lot of employers don't have great data systems around the retention data. So you really have to have a robust HR system that can track that and be able to pull that data out. And I know I've definitely seen that that's a challenge, particularly when you get outside of like the Fortune 100, Fortune 500 companies. So
I think you have to figure out what your company cares about, right? So I handed out a one page that shows some ROI relative to our mental health services. I wouldn't even show that to my CFO. He does not care, because at the end of the day, it's like presenteeism, and they're not solid numbers. I want solid numbers, and so I think you have to figure out what does your organization care about. Well, I can tell you, in my organization, we care deeply about engagement scores and we care about retention. And we can show year over year, as our engagement scores have gone up, as our retention has gone up, our profitability has skyrocketed. And so we call that our secret sauce. So then I go back and I say, okay, how can I build in mental health services to show it's going to help retain people and that engagement is going to go up? And if I can figure out how to do that, then I'm talking their talk. And so for us, it was just about getting one or two counselors in there at a time, taking really, really small examples, and then building upon that to show the value that we're providing.
So as consumers watching and listening, what I would really be paying attention to is the external drivers. If unemployment continues to stay low or goes lower and the job market tightens, and I'm that railroad or I'm that employer, and I've had hundreds of employees in my career in different businesses. Hiring and sourcing and training talent is difficult, hard. And so you're going to see benefits, I think, one of the benefits to low unemployment is benefits get better because employers need to get smarter about what I do to attract and retain my best talent so they don't jump ship, because when the job market's tight, employees start to get finicky and start looking around. You got to give them a reason to stay. And quality benefits, especially unique benefits like the EAPs that are out there and the ones that have real value that differentiate one employer from another. Just put yourself in those shoes when you're evaluating it. If everything else is equal, who's giving me those types of perks and really life-changing valued benefits that are going to make my family's life better?
I'd also like to add to go along with the gentleman's question, you got to have some pain in an organization in order to see change. We didn't see EAPs got started because of people like Jim Kemper Jr., who ran Kemper Insurance because he was a recovering alcoholic when AA was in its infancy. Okay? More recently, and I don't work for Walgreens, but I have to commend the Walgreens organization. Their son and their daughter-in-law had alcohol and drug problems. And because of their son's addiction, and then I believe he met his wife in treatment, they suffered for years. Walgreens, for a period of time, pulled alcohol off of their shelves. Okay? That affected their bottom line. But they put their money where their mouths were. And they started advocating for chemical dependency treatment. Things have come a long way. I ran a treatment center in the 80s, where, people would come into treatment for 30 days, and it was $35,000, and it was 30 and 30. The reason we had 30 and 30 days and 30 days of treatment, was because we had 30 lectures to go through over 30 days. Now most people go to outpatient treatment. We have medically assisted treatment now. But where is the pain? If there's pain in an organization where the CEO's kid overdoses, where somebody in senior leadership has a mental health problem, or is humbled by something like the 9/11 experience where they lost friends and they went through depression afterwards, that's when things change. And until we talk about it and get people to see the value, it's not going to change. On the high deductible plan idea, we do that. I'm a small employer as an EAP. We have 16 employees, okay? But we have a $5,000 deductible. My business partner and I pay the first $3,000 of everybody's deductible, okay? Most people do not use more than, I think, $2,200 or $2,500 worth of medical dollars during a year. So if you can help your employees in that way, in an industry where we can't pay, Wall Street salaries, that's one way of dealing with the system and helping people.
Any other questions? Okay.
I'm coming from the perspective of a real strong supporter of the Kennedy Forum. I'm coming from the perspective of a CEO and as having very serious mental illness with a son, including suicide attempts, and all that goes with that. I've attended every session that this organization has put on, talked to them with them monthly. I attended this one, quite frankly, of interest of what's really new here. The pitch that the CEO has to take more leadership or has to realize that there's a benefit to taking care of his people doesn't ring well with me. It's a given. What I'm taking away from this is that the root problems, which start with inaffordability to get the right kind of treatment. That relates to high deductibles, out of network, and that kind of issue. The fact that the best, at least here in Chicago, and I know this Chicago area very well, psychiatrists, social workers, they don't take insurance. They don't need to. I guess, I think, and the Kennedy Forum's been doing this. The issue in my mind is not so much trying to educate, motivate CEOs or human resource people. The issue is the fundamental problem. I've been there, okay? And I've taken measures. And you know what happens most of the time? You introduce the program and the people that are providing the service don't handle it well. And you got more of a problem with your employee than you did to begin with. All the time. I sit on boards, okay? Nobody's spending a lot of time talking about medical insurance, talk about bonuses, all this kind of stuff, how we get to attract and keep good people. Because the system's broke. It doesn't work. My only thought as a CEO, and what I look at, is the leaders in the healthcare area, the Mayo Clinics of the world, who I know very, very well, okay? People who are really on cutting edge when it comes to the physical, the mental treatment, the whole ball of wax. People who are getting into long-term care so you get the right diagnosis, that kind of thing. I think that's where the leadership's going to come from. They're going to put the pressure on the Blue Crosses and the Blue Shield people. I mean, it's absolutely ridiculous what's going on in terms of coverage there. Just food for thought. But I can tell you, as a result of this session,
I think it's a great point, too.
there's
Mayo.
no major takeaway. I mean, I hear, and the other part that really bothers me is this kind of this attitude that we're not going to change. I mean, it's pervasive of the whole, the people in the key positions, you talk about pain, they aren't feeling any pain, okay? That's what it takes. So,
I think the role of the health system is a great point, and I think we do see on the physical health side, Mayo is a great example where they have become a center of excellence around surgical care, and there's a great case study of Walmart will actually fly employees who have been told they need spinal surgery to Mayo for an evaluation, and no, I understand your point. Sure. No, I understand your point. I think it's a great example of how employers and a health system of excellence can work together to provide high quality care that also delivers value to an employer, because the employers actually get better outcomes and spend less money in using that center of excellence model. And so I'm wondering if you guys have heard of examples, I think you've mentioned it, where finding the right providers and partnering can deliver value to your employees and allow them to have access. I don't know if Mike, you have other examples of where these kind of partnerships with the healthcare system can help our employers deliver value to their employees of quality service.
Yes, and that's the problem. You know, employers would not think they have to contract with cardiologists in the area to meet the needs of their employees. They wouldn't think they'd have to contract to get special treatment so people could see somebody who just had a heart attack. They wouldn't think that they'd have to, you know, beg, steal, and make 20 calls to get somebody in who again could die within 24 hours. They wouldn't think that way. So I'll bring it back, because I want to go a little bit broader than that, because I think you said what's new here, and I'll start with what's broke and then what's new. Okay, what's broke is we, and I put myself in this category too, we built a system that was doomed to fail. We capitated and siloed mental health. We did that. The benefits people did it. The consultants did it, and then they didn't raise those caps. I was on a panel at OneMind 6 months ago, and I went through this whole thing, and then somebody from one of the plans got up, and he says, you know, what he's saying is right. You know, I don't think we've raised fees in the mental health area for 15 years. You haven't raised fees in 15 years, and you're wondering why people aren't participating in networks? You know, when you say we undervalue the services, that's absolutely true. Right? And to get out of there, it's going to require us to change, right? Everything that we built is changeable, but we need to do it. And the way that the existing providers are bought are in a way that doesn't allow them to provide the services that are needed. So where do we need to go? So what that has led to is a system that tries to prevent care. And what we need is a system that tries to promote health. And our EAPs have been passive, and this isn't universal. I know there's a lot of major employers that have very progressive EAPs that take a more positive population health approach to the population. But what employers need to do is think of mental health in the context of their overall health strategy. Yes, not on a siloed basis, but on a holistic basis. They need to be more comprehensive and proactive in that. That's not waiting for people to call the EAP, but looking for the pockets of issues that they need to deal with in that organization, and then going to address them with their partners, their EAP partners and other partners, and then insisting that the system take care of itself. You know, yes, Mayo integrates behavioral health in. They're a good behavioral health provider. But if you talk to behavioral health providers, there's a reason they don't participate in networks. They make 3 times as much not participating in networks. They don't need us. The only reason they participate is because it's their professional, they want to do right. These are good people, they want to do right. But we got to meet them halfway, and we're not meeting them halfway. So I think this group, cannot let the pressure off. We got to move the system. The system will not fix itself, and part of the problem is us.
I want to just chime in on that. Again, I always go back to the math, so I apologize for being the money guy. that point is so dead on. And just put yourself in the shoes that most of the behavioral health providers, outpatient makes up the bulk of the community, and put yourself in the shoes of that professional. And you have so many hours in a day to help so many patients in that time frame. And unlike your acute care brothers that has an office building of billing and claims specialists that take care of everything for the acute care doctor, that poor behavioral health doctor probably has one office person who keeps the books and makes appointments and stuff like that. And that person is supposed to navigate the complexity of submitting claims for reimbursement, denial management, and all that stuff that creates that chaos. They become like the plastic surgeon who says, I don't want your insurance. I don't need your insurance. I only have 8 hours a day. That means 8 patients. I only need 8 self-pay patients to fill up my schedule. And that leaves the entire rest of the patient population with nowhere to go. So you were so dead on. And the trick is, don't take your foot off the gas. My son, and I'll just end with this, I had to commit my oldest boy when he was 29 years old. Ooh, every time I think about that, it drives me crazy. And I had to be there when it happened. And I could not find a psychologist for him. Could not find one. And then I was like, as the parent, right, it's whatever it takes. So I was like, find whatever doctor you like and tell them to send me the bill. What if that's not an option for somebody? Right? So, good for you. Good for you. Don't take your foot off the gas. I love that. Thank you.
Mark, did you want to?
Yeah, so what I'm going to say isn't going to solve the problems that were so well articulated here, but I'll just kind of maybe challenge the group to think about the healthcare system, and the behavioral health system in another way at the other end of the spectrum in terms of the creativity. What we talked about here is how intimidating and daunting the system can be. One thing we found success with is with our peer support networks. And not that the peer support networks provide therapy and solve problems, but we've trained about 750 peer support volunteers across our system who are navigators for our employees and can kind of speak to, and we train them not only in mental health first aid and QPR and things like that, but we've also trained them in what their benefits are and how they can access their benefits. So we do 3 regional meetings a year with our peer support volunteers. We bring in some speakers, then we do breakouts. But the idea is that they're connectors then, and they're talking to folks in and out of crew rooms and sheds and all those kind of things about how to access their benefits. Did you know you have this? And, insurance is kind of scary, right? And a lot of people, the mailings go home and they sit on the cupboard and nobody ever reads them, right? But if you have somebody out there who you see as your advocate and they're common to you, they're like your brother or sister, you have credibility. And so we find a great deal, so you talked about the leadership from the top down, and we certainly have that, but we're also trying to do it from the bottom up and get our rank and file to support their other folks, and it also fits kind of with our vision, mission, and value of the organization as well. So I just challenge everybody to think about how you can use peer navigators in any way that's unique to your system to connect.
I love the fact that you're talking about creativity. And as an employer, it's a little bit different when you're not providing the service, but you're actually trying to provide the service, and you care so deeply about your employees and trying to help them through all these major situations. But that's exactly why we have on-site mental health counseling, is to make sure that they have support, that they have someone that they can go to. We're also redesigning our benefit program as a self-funded program so that we can go with carriers and with partners that allow us to carve things out. So we're going to create our own networks. We're creating our own hospital system that wouldn't contract with a large carrier in our area. So we're going to carve that out and pay them directly. And leaving this conference, I'm going to go home and suggest the exact same thing for mental health, because what I heard here today, which maybe I wasn't resonating with me, is the insurance carriers aren't paying enough. Well, to me, it's worth it, so I'll pay enough, and I'll pay them directly.
That's great. I think we have a couple questions over here in the yellow, if you want to stand up, because you match.
Yes.
I can repeat the question if you want to.
So I'm one of those providers, and I just want to say we're in network with 10 insurance companies, and
So the question is around preferred providers, and when making someone a preferred provider, are employers asking for data, and what kind of outcomes data are they looking for in that process? And I think in the same way that in the physical health side, we're seeing a movement to accountable care. It's a similar kind of question about what kind of outcomes are people asking for to become preferred mental health providers. So, Mark, you mentioned that you have a network of them. I'll start with you.
That's a great point. You made me think about something that I hadn't really thought about before. I've been at Union Pacific for 15 years, and most of the preferred providers, I had the EAP programs, now I have all the medical programs, but we inherited those folks really through relationships. And I don't know that we're asking the right questions on, what are your outcomes. We do have, with the exception of, we use about 3 different substance abuse centers, which we consider to be centers of excellence, and we do track data on them, and they're organizations that really specialize in the care and treatment of employees in the transportation industry. But you made me think about, we need to ask better questions about our individual practitioners out there in the community in terms of what are their data sets. My guess is, since we use a lot of individual providers, they're not tracking a lot of that, right? But it's a really good thought and something I need to kind of consider. The other thing is, we know is a lot of providers are going to be retiring in the next 6 to 10 years, and so we'll need to replace those individuals to make sure we have that access in place.
I just wanted to pile on it just a little bit. I had dinner with Mary Gilberti from NAMI, and one of the things she said is, we always get left behind. All this innovation going on the medical side, where's the innovation on the mental health side, to your point? And so what we talked to her about is this idea that we're moving to bundles on the medical side, and we started talking about how bundles potentially could be an alternative way that we start, not on a capitated basis, but on a treatment basis that allows that. And one of the areas that we're actually starting to work that issue is in substance use disorder. So it's very parallel in terms of some of the issues that could happen on mental health. So I think we have to get out of the box to figure out how to get out of this box, because we are in a bad place, and we need to come up with a solution that enables, high quality providers that are doing the right thing to get rewarded and fairly compensated. And we need to get there in a way that's more accountable and all that. So I'm totally supportive. What a great way to end.
I'm going to end there because I think we have to get out of the box to get out of the box is my favorite line of the session. Thank you all for participating, for asking great questions. Thank you to our panelists for all of your insights. This has been great, so thank you to you. We are seeing you in lunch, so please have at it. It's in Gar Hall. A reminder that Barbara's bookstore will be set up there, and some of today's speakers will be signing books, and then after lunch is the next round of breakout sessions.